Hello and welcome to this latest BJA broadcast from the British Journal of Anaesthesia. We're looking at the August 2021 issue of the journal today, and we've focused on two papers that have as a theme the effect of the COVID pandemic on surgery. Now, this study was done in England and Wales, and we'll be discussing the context of the problem and how it might impact currently and in the future on our surgical services. And I'm delighted to be able to introduce to you or welcome to you four members of the team that are behind this work. And first of all, I'm going to ask them to introduce themselves. So Tom, perhaps you could start.
Hello, my name's Tom Abbott. I'm a clinical lecturer in anaesthesia and an anaesthetist at the Royal London Hospital in London, and thanks very much for inviting us to talk today.
And Izzy?
Hi, I'm a registrar in anaesthesia and intensive care medicine, and I'm an NAHR clinical lecturer, also based at the Royal London.
And Alex?
Hello, I'm Alex Fowler. I'm a doctoral research fellow, also based at the Royal London in Whitechapel.
And last but certainly not least, Rupert.
Hello, I'm Rupert Pearse. I'm a professor of intensive care medicine at Queen Mary University of London, and I work in intensive care at the Royal London Hospital.
Great. So perhaps we could start off by having some context for this work. And obviously, you were all have been working in the clinical setting during the pandemic. And I just wonder if you could explain to everyone how the pandemic has affected the surgical services in your hospital. Izzy, do you want to tell us about your experiences?
So I was based at Bart's Hospital doing my cardiac anaesthesia block from November until March of this year. And like many other trainees will have experienced, a lot of elective work was paused, and a lot of the semi-urgent work or needing intensive care post-surgery was also stopped due to the need for additional intensive care beds. So that was my clinical experience during that time.
Okay, and Rupert, anything to add from your point of view?
Yeah, well, I mean, we saw huge changes over the last 18 months from the first wave through that big long second wave over last winter to the little wave we're having now. And throughout that time, we saw our surgical services being disrupted in lots of different ways. In the first wave, it was quite rushed. We ended up using post-anaesthetic recovery units for makeshift intensive care units, both in paediatrics and in adults. We ended up redeploying all our anaesthetic colleagues to help deliver that, which meant that a lot of surgical services had to shut down. As the wave subsided, we then worked hard to restart surgical services. But then, of course, that big second wave started in the autumn of 2020 and started to disrupt surgical services again until it reached such a serious point where we're actually asking consultant surgeon colleagues to come in and support our ICU nurses to deliver patient care for COVID at the very, very peak of the situation. And now we're in a sort of hybrid where we have a quite significant COVID demand in intensive care, but not so huge that we're having to completely shut down surgical services. But it's still very, very disruptive. And we're seeing all sorts of impacts on the case mix of patients that we care for. So it's a really big change in the job that I'm used to doing, which involves a lot of care for surgical patients, both elective and emergency and intensive care.
And I imagine quite an impact on the staff, not only the medical staff, but the nursing staff and theatre staff.
Yeah, I mean, it's been really hard. People are really tired. Some are affected in different ways. There seem to be some people that everything seems to bounce off them. Others are struggling a bit with post-traumatic stress and various other problems. But I think mainly we're just really, really tired and we all want it to go back to normal. But it doesn't look like it's going to go back to completely normal anytime soon. But vaccination has helped a lot in terms of keeping things under control in the UK, at least. Yeah,
I wonder whether we'll recognise normal when we see it, if we see it again. So when did you start thinking about putting together the data that's formed these papers?
I think that probably Alex and Tom may be best placed to answer that. I don't remember it being my idea. I think we all felt that there was a lot of disruption in what we were doing. And I think we were also all very, very worried about our surgical patients developing COVID at the same time as we were very worried about the impact of all our infection prevention and control and how it might reduce the capacity of surgical services. So I'd probably ask Tom roughly when it came to light.
Yeah, thanks very much. I mean, this work really developed out of an obvious need to understand the changes to surgical services that came about as a result of the pandemic. And we really built on some experience that we had working with these sorts of routinely collected data from projects over the last 4 to 5 years, where we've used national level data to try and understand what happens after surgery, the impact of surgical care on individual patients, and how the surgical population is changing. So it seemed sort of natural for us to try to deploy some of the techniques that we've used before in the pandemic to try and understand how things are and how services have changed. It's important to say from the outset that this was a project that was a part of a wider collaboration. We worked very closely with some colleagues at the University of Swansea, a group of plastic surgeons, but also with colleagues working at the Sale Data Bank, which is the national NHS registry in Wales. And we're very grateful for funding partners both in Wales locally at St Bart's charity, and also for NHS Digital for providing us with the data to run these analyses.
Yeah, and there was the precursor to this was some work we did. NHS England, I think with the Royal College of Surgeons, published a list classifying procedures into 4 groups and said, this is what you should try and continue doing as you were. These are things that you can probably delay by 1 month. These are things you can delay by 3 months and 4 months. And so we did a previous paper that was published sometime end of last year where we looked at modeling out scenarios for if these surgeries were stopped and restarted. And there was some really great data infrastructure in place that we could use to kind of look at the data in a rolling fashion and enable us to understand how surgery had actually been affected. Because I think there was lots of uncertainty, particularly at the start of the pandemic, about what was going to happen. And so to be able to use the data sets that were available in England and Wales was fantastic, to be able to try and understand better about what was being stopped and for how long and how it was recovering.
Yes, and the NHS, I guess, has an interesting history with regard to data and IT, doesn't it? Younger ones of you may not realise how interesting it has been. But I just wonder whether you can tell us a little bit about the data sources that you've used.
Sure. I mean, for these analyses, we used routinely collected data that are collected about all episodes of care in NHS hospitals. So these analyses relate only to care sort of provided or paid for by the NHS. They're generated at the end of each period spent in hospital. And nationally, we have data for roughly 20 years across England and Wales. They can contain various amounts of information, but the access to the infrastructure and availability of data was stepped up during the pandemic to allow projects to understand the impact of the pandemic on healthcare services, and we were fortunate to be able to include our project within that. In Wales, they have a really great infrastructure, which is coordinated by the Sale Data Bank, and we were able to collaborate with those teams at a national level to try to include the Welsh data with the English data that we used.
And approximately how many patients or patient episodes are we talking about for this whole data set that you've used?
So I would need to check quite a lot. So the way that HES works is for every episode someone spends in hospital, there's an episode, there's a sort of a row in the database. So the overall HES data set contains, I think it's about 1 billion records across, in England, because sometimes people may have multiple rows. In terms of our surgical activity paper, we obviously compared historic data to the data that we observed in 2020. And sorry, give me 2 seconds to check the exact number. But it was somewhere in the region of 20 million surgical admissions that we looked at for the volume of surgery paper, for the paper exploring how the surgery changed with the pandemic. And then it was around 3 million patients we looked at when we looked at the mortality associated with a SARS-CoV-2 infection.
And what proportion of the patient episodes would you say have a complete data set, or is there lots of information missing, or is it pretty good?
So the data quality in these data sets has been looked at in quite some detail, and it really improved a number of years ago when payment by results came in. And that means that the way that money flows through the healthcare system is not entirely dependent on coding, but it is heavily influenced by coding. And for certain things, it's very, very good. There have been independent audits of this, and particularly for things like procedures that people have, it's very good. And for important diagnoses, it's pretty good. So for example, there have been quite a lot of papers looking at things like dementia capture. And if people have dementia, it's pretty good. If people have things like eczema, it's not so good. So for important diagnoses and for procedures that people have had that need to be paid for, the quality of the data is good. Now, we weren't sure what the quality of the data was going to be like. Obviously there may have been changes in coding practices, for example, during the course of the pandemic that could have influenced some of our findings. But we were reassured that what we found mapped with the course of the pandemic as we knew it had happened. So we knew that there was likely to be a very large reduction in the first wave when everything was so uncertain and there was so much disruption while people were trying to work out the best way to manage these patients, with a gradual recovery and then things dropping off again. So yes. Okay,
now in terms of the data, obviously these data sets weren't designed to be used by anaesthetists. Is there any information that would be really interesting that you haven't been able to access because it's not collected?
So I think despite a lot of variables being collected and the wealth of the depth of the data, two key things, one of which is ASA score for patients, because clearly a lot more decision making in terms of the severity of when surgery needed to happen and the level of comorbidity in the patients. And also it would be interesting to look at anaesthetic technique, because obviously there's been quite significant changes to our general approach to patients, both with confirmed and also with suspected COVID infection.
You've got millions of episodes, patients' data. What are the challenges in taking those data and getting the information you need out of it?
I think with these data sets, we're mindful that we're using them for a purpose that they weren't initially intended. These are administrative data sets. So we're essentially repurposing the data, which I think one positive way of looking at that is that we're being very parsimonious with our access to data. We're using a data which are available to try and get the most out of those data that are there. We're pretty happy that for the procedures that we're interested in, namely procedures that could be classed as surgery, that the coding quality is good. I think one issue that we need to consider with the pandemic was about the coding of SARS-CoV-2 infection and COVID. And there was some differences between the coding of that in England versus Wales. And perhaps Alex could speak a little bit about the technical aspects of that.
Yeah, so I think as Tom alluded to earlier, they had some, early on in the pandemic, the SaIL Data Bank established a very comprehensive infrastructure of data that involved linking together hospital data, genomics data, testing data, lots of information about patients. And we were able to do a sensitivity analysis to ensure that the recording of a code of COVID-19 infection within the HES data aligned with patients testing positive with with SARS-CoV-2. So we did that. I think one of the challenges we've had here, well, two of the challenges. One is that obviously these are quite large data sets. We've had to access them through special routes to maintain patient, to ensure that the data was handled in an appropriate way. And then combining these, when we got these numbers out and we identified these numbers, to then combine those together and to be mindful of, you know, minor differences in coding practices and the way the data are collected was important. And we had quite a lot of learning there to do. But it was very helpful to be able to work with the SaIL Data Bank, who understand these issues in a lot of detail, because it's what they do on a daily basis, to be able to do that.
What I would add, Phil, to that is that these limitations in the data sources, a lot of it hinges on what questions that you ask of the data source and how you ask them. So you'll note with not only these studies, but also a lot of the work that Alex, Tom and Izzy have done in the past, that we avoid drilling down on very, very small subgroups, because that's when the lack of covariate data such as ASA score becomes much more important, because you can't risk adjust to compare patient groups as easily. But when you ask very, very high level questions at a big population level using millions of patients, a lot of these little discrepancies in the data, these little uncertainties in the data, iron each other out, because they're usually present at random. Missing data are usually missing at random. And so you can draw quite firm and quite robust conclusions at a big population level. What you can't then do is answer that specific question from, say the vascular anaesthetist about whether it's better to do a regional technique for a particular type of vascular procedure, because you end up looking at subgroups of subgroups of subgroups, and the sample sizes get very, very small at that point. And then these discrepancies in the data do become problematic. So a lot of this is about you being very, very cautious about not asking too much of the data. And there's always that temptation to do lots and lots of subgroup analyses. And we work quite hard to resist that temptation.
Mm-hmm. Okay, so that's quite a bit of technical stuff, isn't it? What about the exciting things? What you found? What are the things that excited you most about your findings? Maybe Izzy, start with you.
I think what I found surprising was the differences in terms of, I guess, what can be interpreted as access to healthcare. So during a period where, based on our previous research, we were anticipating lower levels of elective surgical activity, we also found that emergency surgery numbers were also reduced. And I guess maybe Alex, you can allude to some of the different reasons why we thought that came about.
Yes, I mean, I think in terms of exciting findings from the activity paper, 1.5 million procedures fewer per year, which, considering about 4.5–5 million operations are performed each year across the UK, that's a substantial amount. That aligned roughly with our previous modelling, which was satisfying. I think, as Izzy alluded to, there's a very interesting reduction in emergency surgical activity, which was something that we weren't quite anticipating. You know, I wouldn't have, before the pandemic, I wouldn't have necessarily thought that there would be a reduction in emergency surgical care. I think it aligns with something we saw locally, which was that as a major trauma centre, we're seeing a lot of trauma. Rupert, perhaps maybe you want to comment on this, but there was certainly seemed to be a reduction during the first lockdown of trauma-based activity, and presumably that would be part of the reason. Secondly, so that would be a sort of reduction in the prevalence of traumatic injury, which would necessitate surgery normally. Secondly, that I think some of emergency surgery is likely related to treating complications of elective care. And if you're doing less elective activity, you don't develop those complications that need to have an emergency laparotomy afterwards to sort of recover those. And finally, I think there is a very real possibility that there are patients who decided not to come in, and those patients who needed emergency surgical treatment didn't present for it and therefore didn't get it. And something we're looking at or planning to look at is how these reductions in surgical care have affected overall population level mortality. And I worry that patients have probably fallen into that group and sadly have died as a result of having treatable emergency surgical conditions that they haven't necessarily presented to hospital with.
I mean, I think this is a really interesting question, and we'll probably be studying it for a long time, because there's all sorts of other anomalies. It goes beyond surgery. There were interesting patterns in a number of people being admitted to hospital with myocardial infarctions and with strokes. And certainly some of that will be a simple function of people not knowing whether they should go to hospital or maybe being frightened of going to hospital. Some of that will be the impact of the behavioural changes of lockdown. We've never seen a massive population level curfew like this ever in my career, probably in living memory since the Second World War. And so it's a very novel, it inevitably has effects that we can't predict. So I think we'll be teasing out why health behaviour has changed so much. Is right that some of it will be related to access, but there may well be other impacts of just how society's behaviour has changed over time that resulted in different patterns of hospital admissions. What's interesting now is that our pattern of admissions are approaching back to normal, even though we're in a COVID wave, but that COVID wave is controlled to a certain extent in COVID vaccine.
I should say that we published two papers that you mentioned earlier, Phil, one of which looked at surgical activity, and Alex sort of summarised that we saw a 1.5 million patient reduction in the number of procedures performed compared to previous expected levels. But we also looked at the relationship between SARS-CoV-2 infection and post-operative mortality. And I think this is really interesting because we found that during the pandemic in 2020, 1% of patients had an infection with SARS-CoV-2, and that was associated with a 5-fold increase in the risk of death. On elective surgical pathways, there was a very low incidence of COVID infection, SARS-CoV-2 infection, at about 0.1%. But those patients undergoing elective surgery that either had or acquired an infection with SARS-CoV-2 had a massive increase in their risk of death, a 25-fold increase, which is crazy. In the paper, if you look at the Kaplan-Meier plots, the separation in the curves is astounding, and I've not seen that quite so well presented before. And I think we can draw some important conclusions. Firstly, that the pathways that we implemented during the pandemic for trying to control that infection in hospital and safety net worked, in that there was a very low incidence of infection on that pathway, but also the risk of death for patients undergoing elective surgery that had SARS-CoV-2 infection was so big that we need to be really careful about moving forward. And Rupert says that, and I agree that that we seem to have an increasing amount of surgery going on now in the context of the pandemic, which is still not over, and we just need to be cautious about relaxing those restrictions too soon, in my opinion, because our data are showing that there is still a real danger.
Were you able to determine when the surgical patients acquired their COVID, or was it during any time in the hospital episode?
Alex, are you able to just come in on that technical aspect there?
Sure. So one of the wish lists for HES data is good dates of diagnoses that we should add to Izzy's list of ASA grade and type of anaesthetic approach. So we stratified people based on when their SARS code first appeared. And we also looked in the Welsh data using the actual testing data to do as a sort of comparison. And amongst the elective patients, the vast majority were either during the index hospital admission when they're having inpatient surgery or shortly after. And I mean, I think just very quickly, I think one thing that was very reassuring, one question that we had was actually, was all this disruption going to cause the overall rate of surgical mortality, irrespective of if you had COVID or not, to go up? And there was a very slight increase, which probably reflects the fact that higher risk patients with more urgent need for surgery had a need for surgery, and therefore they were more likely to be operated on. But it was not something that looked like it was a kind of catastrophic increase in the rate of death after surgery. So yes, sorry, just to add that to Tom's statement.
But it begs a greater question about the overall risk of death in surgical patients attributable to the pandemic. And I think what we've done here with these analyses are, number one, to show that the number of operations that were going on during the pandemic was greatly reduced. The impact of that reduction on overall mortality of surgical patients is unclear. We know that patients that acquired or had SARS-CoV-2 infection either during or immediately after their surgical episode were at a greater risk of death, and so we can infer things about the direct mortality risk of having a infection with COVID among surgical patients, but we don't know what the impact of changes to the system were on patients waiting for surgery. We don't know what the change, the impact of the change in categories of surgery, i.e. if somebody was scheduled for an elective procedure and it then deteriorated because of a delay and they then presented for emergency surgery, what the increased burden of risk was in terms of their mortality. And then for patients that perhaps would have presented to their GP or to a surgical clinic that was cancelled during the pandemic and went undiagnosed, what the risk of death among those patients are. And we're trying to look at this in another analysis that we'll be conducting in the next 3 to 6 months to really answer the question about the overall burden of risk of mortality among these patients.
Yeah, but I would say,
reassuring. Sorry, Phil.
You carry on, Rupert.
So I think it's very reassuring that we can say that those green pathways, the COVID safe pathways for elective surgery patients, are safe in the UK NHS, and I think that's a really important message. Obviously, as Tom says, that those patients who do get COVID have a substantial increase in mortality, and that is very worrying. But those numbers are very small, and that provides really good evidence that these green pathways are working. But it does also mean that the impact that has on our surgical throughput, our surgical capacity, we've lost about 10% of our capacity, maybe more, because of these green pathway infection prevention control measures, but they do seem to be necessary. There is this broader existential question, given the number of patients now waiting for surgery, the total perhaps as high as 2.5 million in the UK is, and still rising, is whether all of those surgeries will ever get done and what the impact of that will be on those patients, because we are seeing a steady incremental increase in the volume of surgery done in the NHS each year. It rises by 1% a year, and that's a substantial rise, and that's been going on for a long time. And in particular, we're offering more surgery to older people. What's less clear is whether each of those additional surgeries is bringing benefit. For sure, a lot of them will, but is absolutely every one of those extra procedures necessary? And in the context of having a huge backlog of surgery, I think that's going to be a very interesting question for society to answer.
Well, I mean, you've put some really interesting points, and you've actually made some projections in your paper about how long this is going to impact the NHS into the future. And as you've already said, we're certainly still in the pandemic. COVID isn't going away. So are you able to tell us a little bit about your projections and what we might expect over the next few years?
I think Tom is probably best placed to talk to the specific projections that we made in the paper. But the only thing I would add to them is that it's a live situation. COVID is not over yet; it's not gone away, and the situation is evolving over time. I think the NHS has done an amazing job to control the backlog, but we're still at reduced capacity, and it looks like that will continue well into 2022 for us. The impact on other countries that have less effective vaccination campaigns is likely to be much, much higher than we've experienced. So it's certainly a very worrying time for patients with surgical disease.
I mean, I think specifically in terms of what we looked at in our analysis, we have very good data about historical trends of the volume of activity, and we've reported on this previously. And we know how many operations we would expect to occur in a typical year, in a typical month. And we can make adjustments for as Rupert says, the gradual increase year on year in the number of procedures. And in our activity paper and in a previously published paper where we modelled the impact of the pandemic, we show 1.5 million patient reduction in the number of procedures carried out. And the unfortunate thing is that at the moment, the level of activity is still not back to that baseline level. And so while we've accrued in 2020 that 1.5 million patient deficit, we're not yet at the point where we can start to recover any of that deficit. And the number of procedures that are not being done is only increasing, and that deficit is getting larger. Now, we didn't specifically look at scenarios for recovery, but on a sort of a personal note as an anaesthetist working in the NHS, it feels to me like we're going to be working at an accelerated rate for many years to come if we want to try and tackle the backlog. And we need to reach a point where we're sort of treading water and we're not adding to the deficit. And at the moment, we've not yet reached that point. I don't know if Izzy, you want to come in on sort of equity of access to surgical procedures, or Alex on the technical aspects.
I mean, so I'll just say we deliberately took a fairly conservative approach with modelling the deficit. You'll notice that we don't include data from the second wave in January, February, March. And we assumed that the deficit would stay as it was, and it would recover at the pace we saw it recovered across the summer of 2020. So I think that our estimate of 2.4 million patients is probably something that's going to be outdone, especially given recent figures published about the expanding waiting list. And I think it's also important to remember that the waiting list was growing before the pandemic came. So actually getting back to 450,000 operations per month will get us back to a state where the waiting list is growing. And we actually need to exceed that if we want to try and clear this backlog comprehensively. And we have to have a very careful think about how we might change things to be able to do that. Thank you.
I guess just to follow up on what Tom and Alex have said, obviously the surgical population is a huge part of the hospital admissions, but also some of these findings that we found from these recent analyses are likely to be reflected in kind of all acute hospital admissions and other kinds of medical and surgical disease and hospital admissions, we're seeing these differences in how people are presenting needing emergency and elective surgery, but potentially there are other changes that we've haven't fully characterized yet in terms of how access to hospital care, secondary and also primary care have changed as a result of the pandemic. And we may find that due to differences in how people, say, of different ethnic groups and also socioeconomic kind of status, as we've seen in previous research, there may be certain population groups who are more affected than others, and that these kind of differences will need to further research to kind of characterize.
Yeah, I think we only need to think about the differential access to vaccines or differential take-up of vaccines to appreciate that those underlying differences are going to impact on surgery. So this is a really interesting picture that you've given us of the situation in England and Wales with the National Health Service. Maybe Rupert, you'd be able to let us know how generalizable you think the situation is to other countries with other healthcare systems.
Sure. So, I mean, it's hugely variable, as you might expect. The story of the pandemic is one of waves coming and going at various times in different countries. I suspect that, broadly speaking, the data we've presented so far is pretty representative of Europe, because it's mainly driven by experience in 2020, and that was pre-vaccination. And so regardless of whether countries have got a successful or an unsuccessful vaccination campaign, I think they'll have a very similar experience across Europe. It's likely to be a much better situation in places like Australia and New Zealand, where they've managed to strongly limit the effect of the vaccination campaign, albeit with lots of lockdowns and so on. So I think their surgical throughput's probably been fairly well maintained. It's harder to say what's happening in the United States, because there's so much variation between states there. So what the overall picture of the United States is, I'm not sure, but I would anticipate a big backlog. Only this morning I was speaking to a colleague in Uganda, and they saw about a 1/3 reduction in their surgical throughput in one of the major regional hospitals in Uganda. So interestingly, perhaps not quite the same kind of impact that we've seen of the pandemic here, but of course they don't have vaccination at the levels we do, and we can expect the impact on them to last a lot longer. So I think in each individual country there's a very different experience, and in all of this we do have to remember that the low and middle income countries are already struggling to access surgical healthcare in the first place, and so the impact on this of this pandemic on them is going to be much greater.
Phil, one other thing I might just add is that I think we're really fortunate in the United Kingdom to have a National Health Service and to have national level data that we can analyse to look at the nationwide systems impact of the pandemic. And I think this is really unique across the world. So we're probably unable to answer these questions in any other country because the data just aren't available. And I think we're really lucky to have had access to these data, and we've been really fortunate to have been able to hopefully draw some conclusions that will help our clinician colleagues to navigate this really difficult time. But I think it just shows the versatility of and also just how really lucky we are to have such a great national system. Can I also just take the opportunity to just reiterate that this was a collaboration, and I just wanted to sort of say that we're really grateful to our colleagues in Swansea who weren't able to join us this evening, Tom Dobbs and John Gibson. And also we're really grateful to some help from the Cell Data Bank, in particular, Ashley Akbari, who sort of really helped us out with the Welsh data.
Okay, well, thanks for that, Tom. Really important acknowledgements indeed. And I think, you know, there's absolutely no doubt that you have provided some data that is going to be crucial in how anybody anywhere operates in relation to dealing with surgical patients in a COVID pandemic, or indeed when COVID is just endemic, in terms of looking towards the safety of patients who come into hospital well for an elective operation, for example, and certainly don't expect to catch an infection in hospital. Absolutely vital that we limit that as much as possible. And you've really shown us, demonstrated quite conclusively that systems that were put in place were effective. And also, unfortunately, you've shown the devastating consequences of those occasions when somebody needing surgery does acquire COVID. It's not a good combination. So thanks ever so much, all of you, for this really interesting conversation. I've enjoyed it. I'm sure all those who watch it have enjoyed it. And for those of you who are watching, obviously you can read the detail in the British Journal of Anaesthesia. And there's a lot of information there, and it really is a great treasure. So thanks again to Rupert, to Alex, to Izzy, and to Tom. And it's goodbye from all of us. Bye-bye.
Goodbye.